Hi everyone, welcome back to another episode of Health Talks, hosted by the Great Physician Ministries. Today we're talking about depression, and we have with us Dr. Akpabio. She's a psychiatrist based at GSH, Groote Hospital in Cape Town. She'll be unpacking today what depression is, some of the features of depression, and we'll get to the management of depression. Welcome, Doc.
Thank you, Dr. Mbanga, for having me.
How are you today?
I'm good, thank you. And yourself?
Okay, thanks. Great to have you here. So tell us, let's just try to unpack depression as it's known. What is depression?
Okay. So I just wanted to start off with mood. Mood is just generally the emotions and how we experience ourselves. So we have a range where sometimes you're feeling happy, other times sad, lonely, nervous. All of these things are the kinds of emotions that we can have.
Okay.
When we talk about depression, we're talking about this intense kind of sadness that individuals feel, and it can be very difficult to shake off. Okay. So when we talk about a disorder, this is where this depressive symptom has been there for a longer period than general, because everybody has moments where they feel sad. But once it starts to become so intense that it's interfering with your functioning, that's when we have to consider whether or not we need to label this as a disorder or a major depressive episode, for example.
Great. Yeah, I know. From obviously my learning, there's major depressive episode, there's major depressive disorder. Then how does one define those two?
So a major depressive disorder is made up of people that have several major depressive episodes, recurrent ones. So major depressive episode refers to a period, so usually for at least 2 weeks consecutively, where individuals have had this intense depressive symptoms that we're speaking of, as well as perhaps other symptoms. For example, anhedonia. This refers to when you no longer enjoy doing the things that you used to do. So maybe you enjoy cooking, but you now either you don't do it at all, or you do it, but it doesn't bring you that same pleasure anymore. Those are the two biggest symptoms that we want individuals to have at least one of them. Then in addition to this, people might have difficult changes in their appetite. So there can be an increase or decrease appetite, and this can come with either changes in the weight, increasing or decreasing of weight. There can be changes in the sleeping patterns, so either too much sleep or too little sleep. There can be what we call changes also in psychomotor activity. So some individuals might become a bit more sluggish, very slow in how they process things and how they do things, while others become agitated, more active, unable to be still, There can also be feelings of guilt, for no reason, unnecessary guilt, feelings of hopelessness about the future, about life in general, feelings of worthlessness, and then very importantly, thoughts about death. This can be, with suicidal ideations, which they may or may not act upon. So when we talk about an episode, these individuals have at least 5 of these symptoms, and these symptoms are not caused by something like drugs. It's not caused by medical conditions. It's not caused by, anything other than just the person's mental health system.
So it sounds like we have to exclude medical causes that can obviously cause all these features you mentioned. No, that's great. Sure. So we've obviously looked at the clinical features of depression itself.
Major depressive episode.
Yes. And then when does one then make a diagnosis of major depressive disorder?
So again, so when you do have these recurrent episodes and you find that the person doesn't meet criteria for other mental conditions.
Okay.
So again, we've excluded that it's not substances or anything like medical conditions, but we also make sure that these depressive symptoms are not better explained by other mental health problems such as a bipolar disorder or schizophrenia or things like that. Then we could consider labeling it
sounds
as a major
very
depressive
interesting
disorder.
and it sounds quite intensive. So in terms of now the etiology or the causality of such conditions, what do you guys see? What are some of the known causes of depression?
Well, a lot of mental health continues to be researched, right?
Okay.
But for layman terms, there are certain chemicals that are in the brain that helps to regulate, our mood, our happiness, our sadness.
Yeah.
The three big ones are serotonin, noradrenaline, and dopamine. There are systems in the brain that make sure that we have enough of these so that we can feel happy or feel sad and so on. And the research shows that there is a little bit of dysfunction in either one or several of these systems when people do have depression. So that would just be basically some of the things that contribute.
Yeah.
And then if we're talking about risk factors, people that are at risk of having the depression, it includes, we have genetic predisposition. Okay. So if you have a positive family history, and especially somebody that is closer to you, so for example, if your mother has depression versus your uncle far away, removed from you, the closer that relative is to you, we call it first degree relatives, the higher the risk of you having possibly having depression. It also has other risk factors include like your life experiences, going through various stressful situations, like maybe the loss of a parent, loss of a partner, loss of a job, being exposed to trauma, for example, abuse or rape or things like that. It could also have to do with your temperament. You understand that some people are a little bit more predisposed to be negative, more neurotic. Yeah. These people are at higher risk of having depressive episodes. Some people are more highly emotionally strung than other people. These are also considered risk factors. And then there is a correlation between some medical conditions, people that have chronic illnesses like diabetes or other autoimmune conditions, thyroid problems, they are also, or strokes, they are also at risk of potentially developing depression.
Okay, thanks Heidi. Okay, so the one thing I learned obviously from this small session is that sadness is not synonymous to depression.
No. And I think that's a very important thing, because psychiatry is there to help where normal emotions or where emotions have crossed the line of
so it's
normal.
okay to be sad.
It is very much okay. That's part of being human.
Absolutely.
Yes.
Okay, great. So it's okay to be sad. We're not saying sadness means you are depressed, and depression does not mean, so that's good to know. So we've obviously now learned about some of the clinical features, how these things come about. And one will ask, how then do we manage this condition?
The depression. Very, very important question. So we will classify the depression into people that have milder symptoms, more or mild, moderate, and severe. So milder could be that it is you have less of those symptoms that we spoke about in the beginning, or it could be that it doesn't interfere with your functioning as much. While people that are more severe might have all of those 9 symptoms we mentioned, or it significantly impacts their functioning, or they're very suicidal and so on. So depending on how severe it is, that can determine what kind of treatment you need. If you're on the milder side, you might benefit from something very simple, such as getting more exercise, or changing the diet, or having more of a support system around you, just talking to a friend and so on. And then maybe some people are able to benefit from seeing a psychologist, talk therapy, and they might be fine. Where there is, and that would usually be the first line of treatment for those individuals. Where there is moderate to severe depression, so the depression is really interfering with your functioning, it might be occurring with...
What does that mean, ID, interfering with your function?
So, generally, for example, I have the responsibility to go to work, to take care of patients. also as a person, I interact with friends, I interact with, partners and so on. You need to be able to engage in your day-to-day life. So if you are struggling to, for example, get out of bed, or you are at work, but you find that your mind is moving so slowly, you're not able to make the decisions that you would usually do. You're not sleeping well anymore. Your thoughts are just constantly about the depression.
And the negative things.
Yes, you see, you can imagine that it then impairs your functioning. So when you're having that kind of more severe picture, we are more likely to suggest starting with medication, where the aim of the medication then is to try and regulate those chemicals we spoke about, the serotonin, the norepinephrine, the dopamine systems in the brain. But then the best is then combining that with psychology. Because, for example, as we've said, a lot of different things contribute to the depression. So, for example, if you are depressed because of having lost a loved one, you might also benefit from having that space to talk about your feelings, process what has happened, learn coping skills and so on. People also benefit from joining support groups, so that you hear that you are not alone in your experience, and perhaps you benefit from methods other people have used.
I think that's
so we call that more of a biopsychosocial approach. So not just medication, but seeing what else can we do psychologically and socially to aid you with regards to your depression.
Okay, thanks. In fact, one of my questions to you was, the interplay between social worker, psychology, and psychiatry. We obviously were in Cape Town, whereby there's easy access or appropriate access to psychiatrists. But someone who's, somewhere where there's no psychiatry readily available, is there a role for social worker and psychology in managing these patients?
Another very good question. For sure, like we've mentioned, especially if you're having more of the milder side, you could start off with seeing a psychologist. And there are also some social workers who are qualified to give counseling, give supportive care. So example, again, when the depression is caused by disarray in the family, for example, or where there's family discord or social issues, perhaps finances and so on, it would be important to involve those individuals. The social worker might be able to give recommendations for support structures that the government provides for you in terms of finances. They might be able to help with counseling for families to help with the dynamics at home that are contributing to the depression and so on. And if there is no psychiatrist available, because the psychologists and social workers are unlikely to be able to prescribe, most GPs are then able to manage fairly uncomplicated depression. So they should be able to at least start a patient on the basic antidepressants, and if for whatever reason the person is not improving, then one can then look at referring to a psychiatrist at that point.
Thanks, Heidi. Okay, so we obviously mentioned the non-pharmacological aspect of the management, and you said then you can further go on to antidepressants. Can you just mention a few of those agents?
So the most common ones that we have is a class called SSRIs, and these ones work specifically on increasing the serotonin in the brain. These are things such as fluoxetine, citalopram, paroxetine, sertraline. These are the ones that most individuals that are being treated for depression usually are started on.
Okay, great. And then what's the duration of therapy?
Treatment? So if we're using medication, if it's your first time that you've been diagnosed with having this major depressive episode, we typically tend to treat for about 6 months to about 9 months, 1 year. Whereafter we can then try and taper off the medication. And if it's now happening recurrently, we would like to treat for at least 2 years. And thereafter, we can see whether or not to wean it off. Some individuals are then able to be perfectly fine without the medication once weaned off, whilst others end up needing the medication to keep them functional.
Okay, thanks Heidi. So Heidi is saying if you have anhedonia, loss of interest, you have increased appetite, decreased appetite, you should probably go see someone. If you are sleeping a lot, you mentioned sleeping a lot, or not sleeping.
Depressed mood. Feelings of guilt, hopelessness, worthlessness, suicidal thoughts especially.
Yeah, so I think, it's time we should obviously go out, get help, see someone. Start wherever you can start. Psychology, social worker, your GP, and ultimately you'll get to meet the psychiatrist. And something Heidi said, which I thought was profound, is that it's okay to be sad. We sometimes feel sad on a daily basis, but that is not equivalent to the diagnosis of depression. But if that is persistent, or obviously with other features, then it's called depression. Now, what are some of the complications you guys see, obviously, in terms of the depression itself, or some of the medications you put on these patients on?
So, with the depression, especially the more severe it is, sometimes it can occur with psychotic features. So things like people are hearing voices or having delusions, so believing things that are not true. And maybe because of those, people might be put in a position where they hurt themselves because of, hearing voices telling them to hurt themselves. Also, when you're depressed, you're at higher risk of having other mental conditions such as anxiety or other personality issues, possibly substance abuse, because some people try to cope with the depression by using substances. Then, as we've mentioned, because it might impair your functioning, you might find that you don't actually tend to yourself as well as you should. So other medical conditions that you might have at the same time become uncontrolled, and you might have, for example, if you have uncontrolled blood pressure, complications of that, having strokes and heart attacks and so on. So it's very, very important that one gets it under control as much as is possible. There's also the social aspects, the isolation because of not being able to keep up with friends or with family and so on. That does come with it, the loneliness. And so on. And then with regards to the medication, the side effects also depends on which medication one uses. Typically the side effects are more common at the beginning of using the medication, and then as the body adjusts to it, it does become less so, where the more common ones are like abdominal discomfort, nausea, vomiting. Some people might experience headaches. Some of the medications can either make you to feel more alert or more sleepy, depending on which one we use. And then, so all of these are then discussed with you when you are about to be initiated on the medication. And we try to reduce the risk of this by starting the medication at a low dose and then gradually increasing the dose.
Okay, thank you. Thank you so much, Heidi. Everyone will agree, COVID-19 has obviously, probably increased the incidence of depression. So join us again next time. We'll talk about COVID-19 and depression. Thank you, Heidi. Thank you for availing your services to us. And, let's go out. Let's seek help. Let's get help. Let's try to reduce the stigma around depression. Obviously, men have a very poor health-seeking behavior. So men, if you have all these things Dr. Heidi mentioned, go out and get help. Let's try to help each other. And obviously, let's try to reduce the stigma. I think that's very important. Let's try to reduce depression is just like diabetes, like hypertension, like migraines, and we should treat it as such.
Yes.
So what are your last comments to our viewers, Heidi?
I think you've said it very well. Stigma is another big topic that we can address. But the same way, nobody feels shame for having diabetes or high blood pressure. There's no need to feel shame for having depression. Help is available, and avail yourself of the help. We don't judge as clinicians, so we are ready to help should you be in need of help. But I hope people have found the information I've shared helpful.
Thank you so much. I found it very helpful. Thank you so much. Join us next time with Dr. Heidi. We'll talk about COVID-19 and depression. Thank you so much. Stay blessed. Remember to subscribe and share these videos. We're just trying to help each other to stay healthy.
And like.
And like, yes. Thank you. Cheers. Bye.